My name's Mervyn Singer, and I'm going to give a little potted history on esophageal Doppler. In fact, when I started using it, I was working in a small district general hospital, and I'd got to love the circulation. I was used to using pulmonary artery catheters, and the hospital I was working at weren't interested in taking on the pulmonary artery catheter. And the consultant I was working for, who was a gastroenterologist, noted a short article in The Lancet about measurement of cardiac output non-invasively. And it was written by a cardiovascular physician from Aberdeen called John Rawls, and I read it and it sounded really good. He made the point in the article that the Doppler monitoring was highly reproducible and goes a long way towards the objective of a simple, safe, reliable and cheap method of assessment. And I thought, oh, this sounds good. And so I looked at the references, and the very first reference related to the guy who invented the technique, and he was called Henry Light. And he was a bioengineer who happened to be working at a research establishment about 5 miles from where I was working as a junior doctor. And so I rang up the department, and he was still there. He was a few months short of retirement. And so I went and saw him, and he explained to me what the technique was all about, and essentially lent me his machine, and I did some pilot stuff on it. It's based on the Doppler equation. So if you send sound waves at a moving object, the sound waves are reflected back off that moving object with a shift in frequency proportional to the velocity of the moving object. So in this case, if you're looking at the aorta, you're looking at sound waves bouncing back off the moving blood, and the Doppler frequency shift reflects the speed of that blood. And with the Henry Light method, the probe, it was quite a big chunky probe. It sat on the patient's neck, and you directed it towards the descending thoracic aorta. Ideally, in my view, you'd want to look at the ascending aorta, but the probe design was such that it was too chunky to get behind the suprasternal notch. However, I tried it and got very good signals, and in those days you got like strips of toilet paper that sort of came out. It was a sort of thermal ink printer that you could print out your signals, and then you got nice waveforms, velocity time waveforms of the blood flowing through the aorta, and then you take those strips of toilet paper, as it were, when they dried, and then you could measure the area under the curve on a bit pad. And basically, and this example here shows an example of a patient who'd had a myocardial infarction. He came in hypotensive, but was reasonably all right. 2 days later, however, he had a further myocardial infarction, and now his blood pressure was unrecordable. He was in cardiogenic shock. And the Doppler waveforms showed a much, much smaller stroke volume. So the area under the waveform represents stroke volume. And we started him on some inotropes. The blood pressure came up a bit, the stroke volume improved. We increased the dobutamine to further augment his cardiac output, and there was a much healthier looking Doppler signal suggesting a much better cardiac output. And in conjunction with that, he now had an acceptable blood pressure. So that's just one anecdote of how it could be used. And here's another anecdote. This is a patient in complete heart block, and we could change the pacemaker rhythm to 50, 70, 90, 110 beats per minute, and we could work out which heart rate gave the best stroke volume, so allowing sufficient time for the heart to fill, but at the same time having a decent cardiac output. And you can see, again, from this example, at a heart rate of 70, he had the best stroke volume. Moving on from that very basic machine, there was a company called Doptek, who were a forerunner of Deltex, who make the CardioQ, and they had Doppler Monitor, the software where you could now measure things on a screen. You'd have to then freeze the screen, and with a light pen, you could measure directly on the screen the waveform. So you could look at the width of the waveform, the height, and the area under the waveform, which, as I mentioned earlier, represents the stroke volume. And shown now on the right-hand side of the slide is another example of a patient in complete heart block, but now it's in glorious Technicolor. And again, you could optimize the heart rate to the best stroke volume. The downside with the suprasternal approach was that you couldn't hold it in place, and I tried various gizmos to try and hold it in place to enable continuous monitoring of the circulation. Unfortunately, I failed miserably, and then I had the bright idea of, why don't we put a probe down the esophagus, because my rudimentary anatomy had taught me that the esophagus sat very close to the descending thoracic aorta, and at approximately the third, fourth, fifth thoracic vertebrae, the aorta and the esophagus ran parallel with each other. So in a normal-sized adult, that's about 35 to 40 centimeters from the teeth. The tip of the probe would be in an esophagus that's running in line with the aorta. The company, Doptek, then very kindly made a prototype esophageal probe, which was actually built in, araldited, glued into a large bore nasogastric tube. And there was an angle on the face of the probe of 45 degrees, because the Doppler equation, there's a cosine of the angle between the direction of the sound waves and the direction of the moving blood. So a known angle was introduced of 45 degrees. I tried it on myself first, but wasn't that successful because I've got a very, very sensitive palate. But I was working with a lady doctor who, without any local anesthetic, just swallowed the probe. We got an immediate signal. It was beautiful, and I was sold on the technique. So within a couple of minutes from beginning to end, I had a lovely signal, and it was just running continuously, showing me very nice monitoring of her cardiac output. The advantage and disadvantage of when I was doing this, and this was in the mid-1980s, was that the electronic age and the internet hadn't arrived, and so I was blissfully unaware that other people had thought of this first. And the first person to come up with the idea of using a Doppler probe in the esophagus was a guy called Ray Gosling, who was a professor of medical physics at Guy's Hospital in London. And his other claim to fame, he was a student under Rosamund Franklin, and she was a famous physicist at King's College London that Crick and Watson basically got the idea for DNA, double-stranded DNA, from her. And so he was there at the time in the background. So he published a paper in Nature in 1971 and essentially showed that you could get good blood flow signals from an esophageal probe, and he had a transducer of 5 millimeters radius. And he got, by today's standards, fairly rudimentary black and white images, but they were clearly waveforms of blood flowing through the descending thoracic aorta. And other groups too in the 70s and 80s had also come up with the idea of esophageal Doppler monitoring. Because we were completely ignorant, we did it from first principles, so we did lots of measurements in cadavers, in CT scans of the anatomy and the distance from the esophagus to the aorta and so forth. And after various iterations of the probe and the device, we now have the commercial version that's sold as CardioQ. And clearly the sound waves you hear on the loudspeaker and the image you see on the monitor can help you correctly orient the probe to midstream flow in the descending thoracic aorta. So you get very different signals if the probe is facing anteriorly towards the heart, if it's facing towards the hemiazygous vein, there's a classic venous signal. If it's too far down, you can pick up celiac axis blood flow. Too high up, you might pick up the pulmonary artery blood flow. And so there's a right depth. There are markings on the probe, so it helps you to insert the probe into a patient of a particular height to the right depth. It might need to be inserted a bit further in a very tall person, or not so far in somebody who's short. And essentially it worked, and subsequently a whole variety of different trials were done in patients having high-risk surgery for a whole variety of reasons, and using the monitor to optimize the amount of fluid they got was able to impact significantly in terms of post-operative complications and the duration of hospital stay after their major surgery, and this applied to abdominal surgery, orthopedic, cardiac, trauma, etc. Subsequently, on the basis of these studies, there were health economic and clinical evaluations by the US and the UK sort of evidence-based review centres, and they gave it a stamp of approval. And so it was recommended for use in the United Kingdom as part of a sort of quality improvement programme. As part of this, there was a study done in a few hospitals, 3 hospitals in the UK, that was published in the British Medical Journal, where they did a before-after study. So they looked at outcomes after major surgery, and then all of the anaesthetists in the departments of these 3 hospitals were taught how to use the Doppler probe, and then they used it, and they found that there was a significant improvement in the length of stay of these patients who had had their intraoperative fluid management carefully titrated using the Deltex cardiac output machine. So is it quick? Is it easy to use? The answer is yes. In most patients, it can, on average, take 1 to 2 minutes to place. Sometimes it's immediate. Sometimes you have to look for the signal for a few minutes. In people with hiatus hernias, where the probe, because usually the esophagus clamps down, it's a collapsible tube, so the probe may be held in place to a large degree by this collapsed esophagus. If there's a hiatus hernia, the probe may float around a bit more. Or if there's nasogastric tubes or other tubes in the stomach, in the esophagus, again, you might have to reorient the probe so that the other tube in the esophagus isn't between the Doppler probe and the descending aorta. Importantly, and in many hospitals, certainly in the UK, the nurses place the probes rather than the doctors on many intensive care units. So you don't have to wait until a doctor comes along to insert a probe. The nurses can do it, and do it very successfully and effectively. And certainly where I work, at University College Hospital, the nurses are empowered to place the probe, and they can give fluid challenges if the patient is seen to be hypovolemic, and you can visualize the response. So you can construct a Starling curve to see that the patient is adequately filled and see if they respond, whether it's urine output or blood pressure or high lactate reverting back to normal with reversion of the hypovolemia. So it's rare to not obtain any signal. In some patients it can take more time. You put some lubricating gel on the tip, and that helps as a surface medium. Sound waves don't travel, or ultrasound waves in particular, don't travel well through air. And so if you have a nice contact medium on the esophageal wall, that helps the signal. With time, over a few minutes or hours, mucus from the esophageal inner wall builds up on the probe, and that actually improves the quality of the signal. There is a learning curve. Like most devices, you have to learn how to use it properly, but it can be ascended very quickly. So usually within 10 goes or so, the novice user can learn how to use the device appropriately and recognize what's a good signal, bad signal, to make sure it's inserted to the right depth, and to be able to interpret different waveforms. Because you hear the signal and you see the signal on the screen, it's very easy to orient a correct positioning of the probe. So you're aiming for a nice crisp waveform with, the fancy term is narrow spectral dispersion. So you have the sort of colours on the outside of the waveform and with a black inside. So that means that you're looking at the centre of the aorta where the blood flow is laminar, so all of the blood essentially is going at the same velocity, and so the black represents no flow. If you're looking across the centre of the vessel, all the blood's travelling at the same speed. If you're looking at the edge of the vessel where friction slows down the blood flow velocity, you then see a much more filled in waveform. So nice, crisp, sharp looking waveforms with a black inside is representative of a well-focused Doppler probe. But you get lots of other information. It's not just the size of the waveform, but the shape that actually provides lots and lots of useful information. So the size of the waveform gives you an index of the stroke volume. place the patient's age, which is a crucial factor, and to a lesser extent their height and weight, into a nomogram when you set the machine up, and that then translates a Doppler signal into a reasonable estimate of total cardiac output. But the waveform shape gives you information on the filling of the left ventricle, the afterload, the resistance against which the left ventricle has to pump, how well that left ventricle's pumping, if there's any obstruction to flow, for example, a pulmonary embolus or a pericardial tamponade. And if you see a reverse flow going the whole length of diastole, you only see that in moderate to severe aortic regurgitation. So it's fairly diagnostic that the patient has a big problem with their aortic valve, whether it's trauma, endocarditis, or whatever. So when you look at the waveforms, you can measure the stroke distance, which is a marker of stroke volume, and this nomogram I just mentioned translates that into a measure of stroke volume. The mean acceleration is the upstroke of the waveform, which is a marker of contractility, as is the peak velocity, which is the apex of the waveform. The flow time is the base of the waveform, and the cycle time is the time from the beginning of one waveform to the beginning of the next. So that equates to the RR interval on an ECG. So you can get from the waveform shape lots of information. Clearly, the filling of the heart is affected by the heart rate. So if there's a very fast heart rate, the heart doesn't necessarily have time to adequately fill. So you can correct for heart rate by using Bazit's equation. So this is an equation used to correct the QT interval to a heart rate of 60. It's the QT interval on the ECG divided by the square root of the RR interval. So you can translate that to the Doppler waveform. Instead of the QT, you use the flow time, and then you divide that by the square root of the RR interval, which is the cycle time. And so at a heart rate of 60, systole is approximately a third of that. So that's 330 to 350 milliseconds. A third of a second is the normal time of systole in a patient with a heart rate of 60 beats per minute. And that value, this corrected flow time value, is inversely related to the systemic vascular resistance. So if the patient is vasodilated, there's a low vascular resistance, so the left ventricle can pump harder and longer. So if the patient is septic or is exercising, has an epidural in place, is pregnant, any cause of vasodilation, the peak velocity goes up and the corrected flow time gets longer. On the other hand, any cause of vasoconstriction, commonly hypovolemia, but it may be that the person is very cold, or there's a flow obstruction, so blood can't get into the left ventricle. So the left ventricle thinks it's hypovolemic, which in relative terms it is, or the patient's being given too much vasopressor. The net effect is you get this very narrow waveform. As the SVR goes up, the corrected flow time gets narrower. As I mentioned before, you can construct a relatively non-invasive Starling curve. So as you give fluid, if the patient does respond to that fluid, the stroke volume will go up. And so you get to a point where the stroke volume no longer increases, and then you're at the top of the Starling curve. And that tells you that the patient is filled. Clearly, there are some examples where the patient may be bleeding out at the same rate that you're putting in the blood, but usually that's known clinically. But in the vast majority of patients, when there's no further improvement in stroke volume to a volume challenge, we use 200 ml fluid challenges given over 5 to 10 minutes, then you know that there's no point giving further fluid. If the patient is still hypotensive, anuric, whatever, you have to do other things rather than fluid, so that protects the patient from iatrogenic drowning. I mentioned earlier that the peak velocity is a marker of contractility. So as you get older, unfortunately, your heart doesn't contract as well. And so for every year of adult life, the performance of the heart decreases by about 1%. So the peak velocity, which in a 20-year-old patient is somewhere between 90 to 120 centimeters per second, will drop gradually with age. So in a healthy 50-year-old, it will be about 60 to 90 centimeters per second. In a 70-year-old, it will be about 50 to 70. So these are normal ranges. So if you have a patient of a known age whose peak velocity is much higher or much lower, that's suggestive of a hyperdynamic circulation. They're septic, pregnant, whatever, or hypodynamic. They have a problem with left ventricular contractility. For example, they've got heart failure. And you can look at the shape of the waveform and how it changes with an intervention or with the progression of the patient's illness. So when you reduce left ventricular filling, the preload, the waveform gets narrower. The peak velocity doesn't tend to change too much until the hypovolemia is very severe. On the other hand, when you increase preload, the corrected flow time gets progressively longer with relatively less effect on the peak velocity. On the other hand, when you change inotropy, the predominant effect is on the peak velocity. It goes up with increasing inotropy and goes down with myocardial depression. And when the predominant change is one of afterload, when you reduce the afterload, less resistance for the left ventricle to pump against, the peak velocity goes up, the flow time corrected value becomes longer, and vice versa when you vasoconstrict the patient. Especially in patients with poor left ventricles, they don't like pumping against a high resistance, and you see quite a marked fall sometimes in the stroke volume as both the peak velocity gets smaller and the corrected flow time gets shorter. Here are a few examples, just case studies. This is a patient having cardiac surgery, and the top trace shows him to be in atrial fibrillation. You've got this nice beat-to-beat variability in stroke volume. It's irregular. He, at the time, had a low blood pressure, and that was sorted out by a DC cardioversion. And you can see now in sinus rhythm, he has a much healthier stroke volume. And these pictures were taken about 20, 30 seconds apart. This is another patient also having cardiac surgery before and after the addition of an atrial pacemaker. So he was in complete heart block, giving the atrial kick. In this case, doubled the stroke volume. And again, these pictures are taken about 30 seconds apart. This is another patient having cardiac surgery who had progressive myocardial depression. His heart didn't like being fiddled with by the cardiac surgeon. And so you can see over time there was this progressive diminution of his stroke volume, the peak velocity went down, and then it got to such a point, it was so bad, he needed to go onto an emergency bypass. This was in the very early days of our learning curve, and we were able to then recognize this and intervene much earlier. We didn't need to allow his circulation to deteriorate to such a parlous state. I mentioned earlier about aortic regurgitation. This is a nice example. You can see the forward flow going up, but you can also see the reverse flow going the whole length of diastole. And this patient had severe aortic regurgitation. However, the picture on the right was after the valve was replaced and it was still there. And post-operatively, he had an echo which confirmed that there was a remaining periprosthetic leak. So the surgeon actually liked having the device in use in his patients to just confirm that his surgery was actually effective. A quick case study. This is a 34-year-old bricklayer, big muscular guy, a 5-day history of feeling unwell, fever, feeling awful, and he was found on the day of admission moribund in his bed. He was obtunded, he was very tachycardic, he had a decent blood pressure, he had a classic purpura fulminans vasculitic rash over his body, and his limbs were really shut down. He was white, pulseless. You couldn't feel any pulses until you got to his femorals. And as you can see from this picture, he had quite a fulminant progressive rash. Clearly, meningococcal septicaemia is on the cards, and that's what he indeed had. How are we going to treat him? Well, clearly, the standard things, oxygenate him, intubate, ventilate, IV access, and then he needed treatment with fluid, with antibiotics, and a call for intensive care assistance. It's not well recognised, but these patients actually, even though they're young, fit, healthy people, normally they often have with meningococcal sepsis, severe myocardial depression. And so I try to avoid drowning these patients with lots of fluid, which is the usual mantra for somebody who's young and in septic shock. So if you're not able to monitor the cardiac output in these patients, it becomes very difficult to know how much fluid to give, when to stop, what drugs to use if his blood pressure falls, should you give more fluid, and so forth. So with him, it was very easy. We put the probe in, his blood pressure was now sagging, he had a CVP of 12, but he had a stroke volume of only 22 mils. And it should be, in him, a usual value would be nearer 100 mils. So clearly, he didn't have a good heart. Clearly, hypovolemia could be on the cards, but he had a fluid challenge. It made things worse. So just with 200 mils and his ongoing deterioration, things were looking particularly grim. He now had a stroke volume of only 15 mils per beat. What do you do now? Clearly, fluid isn't the answer. He needs support for his circulation, for his heart, and anecdotally, a big dose of steroids I find helps these patients. So that's indeed what he had. So he was started on some epinephrine, some nitrate to try and vasodilate him, and a big dose of steroid, but no further fluid. And within 10 minutes, he was still tachycardic, but the cardiac output was much, much better. It had essentially gone up 2 to 3-fold within 10 minutes. And he looked better, his colour was better, and the Doppler monitor showed a much improved cardiac output. Thereafter, he had lots of different treatments and did very well, and eventually lived to tell the tale and went back home. So in summary, the advantages of the technique: it's quick, it's easy to use, it's minimally invasive and safe. There's a rapid learning curve. You've got to go up that curve, but it is rapid. Of all the non-invasive or relatively non-invasive methods, it's by far and away the best validated. And I think that's a very important point, that you've got to have confidence that the technique is actually a reliable measure of cardiac output. As I mentioned earlier, it can be nurse-driven, so you don't need to wait for a doctor to turn up. And it's not just giving you a number, the cardiac output is X, it's giving you an indication of how to manage the patient with fluid, inotropes, dilators, constrictors, whatever. So it measures cardiac output by looking at the flow velocity. It's not a derivation, for example, from a pressure waveform. And of all of the different techniques that have been looked at perioperatively, it's the one that's most consistently shown an outcome benefit. Clearly, there are downsides. The probe can move, so you may well need to refocus the probe, but it's easy to recognize, it's generally easy to perform. We use it in patients with varices and so forth, but clearly you have to be cautious in patients with known esophageal pathology. If the patient is having, for example, an epidural, you'll get lower body dilatation. So even though the trend following is accurate, the absolute cardiac output value given by the machine may not be a true representation. Likewise, pathologies with the aorta, cross-clamping, coarctation, again, the accuracy of the cardiac output measurement may not be so great. Can you use it in awake patients? Yes, you can, although clearly some people tolerate in the awake phase probes better than others. Clearly, if they can tolerate an endotracheal tube, they can tolerate an esophageal Doppler probe, but by and large, we tend to use them more in intubated, ventilated patients, although you can go via the nasal route, which is better tolerated than an oroesophageal route. So in summary, it's a nice, simple device. It's important to learn how to use it properly. It certainly taught me a lot about the circulation, much more than I thought I knew, and it certainly helped me to augment my clinical judgment and my management.